Hello, everybody. We're going to just give a minute till we start. All right, David, can you see my first slide?
We can.
Anybody? Ramsey or Jess, can you see my first slide? Okay.
Yes.
All right. Well, why don't we get started as people are trickling in. So this is our monthly Fast Facts prenatal care reproductive health primer for primary care providers. I am really excited to moderate this. Here we go. So CME, we'll give more information at the end about how folks can get CME accreditation for this talk, both physicians and nurses. We have no financial disclosures, none of us. And what the hope at the end of this session is that participants will understand preconception recommendations for healthy folks, but specifically for primary and prenatal care clinicians, understand the clinical guidelines for optimal care of folks who have chronic medical conditions before pregnancy and during. And then I'll close by talking about IDPH resources for optimizing health before and during pregnancy. There's some state resources that are in this space. So I'm Maura Quinlan. I'm an OBGYN generalist in Chicago, and I'm also the Women's Health Medical Advisor for our state health department. The first part, we are joined luckily by Ramsey Unal, who is OBGYN and subspecialty trained in maternal fetal medicine at SIU in Springfield. After her part, we will have Jessica Zemo, who is in the Department of Internal Medicine at Northwestern with an interest in care for women before and during pregnancy for chronic diseases. So I'm going to stop sharing and turn it over to Ramsey.
Okay, let's see if I'm smart enough to share my screen again. Okay, are you guys seeing the correct view? No?
No, not seeing your slides yet. There we go.
Okay, is it the, no, not the correct view. Is that, it's not, is it showing the correct view? It doesn't look like it is to me. It's still the
It's the speaker view.
Right.
Not the slideshow.
There it goes. Does that look right?
Same for us, speaker view.
It is? On my computer, it looks like the correct view. How about now?
Same for me, the speaker view or speaker, notes.
I will try one more time. That's odd. For me, it looks correct.
If not, David could pull up your.
Yeah, let me just try one more time. Try something slightly different.
There we are. Perfect.
Okay.
Perfect.
Fifth time's the charm, I guess.
Yep.
Okay. Well, as Dr. Quinlan said, my name is Ramsey Unal. I'm a maternal fetal medicine physician in Springfield, Illinois, and I'm very happy to be speaking about this topic today. I don't have any disclosures. My objectives today are really threefold. First, I want us to learn how to approach preconception counseling as part of routine medical care, including routine primary care. how to review a medical history, which I know primary care physicians do all the time, but sort of through the lens of future pregnancy. And then finally, to understand how to help patients optimize maternal and future fetal health. So those are my objectives, but really I would say my primary objective is to hopefully leave everybody listening and watching today with at least 1 or 2 points that either they didn't know before or just hadn't thought of before. And I can tell you that simply in putting these slides together, I myself learned several things. I did spend a fair bit of time trying to figure out how to organize this talk. It's obviously a huge topic and I couldn't cover everything. So I ultimately sort of arranged the talk in my mind into 4 parts. First, I'm going to try to make a case for preconception counseling as preventative care. Second, we're going to review, as I said, a complete medical history, but with future pregnancy in mind. We'll also talk a little bit about genetic screening that we should be offering. There are some advantages to offering it prior to pregnancy as opposed to waiting for pregnancy. And then lastly, we'll talk a little bit about pregnancy timing. So I've never actually given a talk on this exact topic before. So when I went to put these slides together, the first thing I did was pull up this ACOG, which is the American College of Obstetricians and Gynecologists document. It's from a few years ago on pregnancy counseling, and it's a good resource. So I wanted to leave it for you guys here for future reference. In that committee opinion, they cite this paper, which is pretty old. It's over 10 years old. It was in the journal Contraception, and this was a group from Oregon. And they argued convincingly in this paper that reproductive health belongs as a part of high quality primary care. And they were trying to make it easy. They advocated just one key question, that anytime we have a medical encounter with somebody who is pregnancy capable, that we should ask the one key question, which is, would you like to become pregnant in the next year? If the answer is no, the recommendation was to move to offer contraception. And if the answer was yes, to move more toward preconception care. Now, there was a quote in this paper that really struck me, and that quote is this, that prenatal care is a program of surveillance. True prevention happens before the pregnancy. And while there are some exceptions to that, and when I read this, the very first thing that came to my mind as an exception was the use of low-dose aspirin for preeclampsia prevention. But other than a few exceptions, it's really a true statement, and it's a little bit sobering if you think about it. So that idea that prevention happens before pregnancy rather than during pregnancy, it does apply to some maternal aspects too, but it applies very strictly and absolutely to fetal development. So what I have up here is a little bit older, but you'll see anytime you read anything about fetal development or embryology, a chart like this pops up. And I just want to point out that, so these numbers are weeks after conception. And when you look at some of the most important organ systems, CNS, heart, for instance, these things are forming in the first few weeks after conception. So this is sometimes, maybe even often, well, sometimes before the woman knows she's pregnant, and often before she even initiates prenatal care. So this concept is why things like folic acid, so important to start prior to pregnancy. Folic acid, and the next slide has a little bit more detail, but folic acid is recommended to help prevent neural tube defects. That's spina bifida, anencephaly, and encephalocele. And the neural tube actually closes a month after conception. So you really have to be on folic acid prior to pregnancy for it to make any effect. This table and these concepts also show why it's really important to diagnose and control diabetes prior to pregnancy. I think Dr. Zemo is going to probably go over that because poorly controlled diabetes is associated with a much higher risk of birth defects, and hypothyroidism, which she may go over too. It's a little bit different in that when it's poorly controlled, it doesn't lead to structural birth defects, but it can lead to adverse neurodevelopment. Speaking of folic acid, I think it is probably widely known that all patients of pregnancy-capable patients should be on folic acid supplementation. 400 micrograms is the general recommendation. And you'll read different things as far as how long prior to conception you need to be on it, but somewhere between 1 to 3 months prior to conception. The exception to that dosing in patients who would still be considered healthy would be if the patient has had a prior child who had a neural tube defect. She should be on a much higher dose, 4 milligrams. There are also some reasonably common medical conditions for which higher doses are indicated. Things like sickle cell disease, where you have higher turnover of red blood cells, diabetes, seizure disorders, and then sulfasalazine use is another example. We'll turn our attention now to reviewing the medical history, and as I said, kind of through the lens of future pregnancy. And I just want to point out that a lot of this, if there's primary care providers or people who work in primary care in the audience, you'll probably be thinking for most of my slides, well, yeah, we do that, all the time. And I just want to stress that, yeah, routine primary care is preconception care. We clearly want to review all medications, and that applies to prescription, over-the-counter medications, also asking about herbal supplements. And for a lot of medications, if you look it up, it's pretty clear whether something's okay in pregnancy or not. But for a lot of medications, it's really difficult to sort through the available data, and often it's lack of data on whether or not medications are okay in pregnancy. So I would just say if there's any doubt about whether or not certain medications are appropriate in pregnancy, just consider referral to maternal fetal medicine for review. And to get on my soapbox just for 1 second, for patients who have chronic medical conditions that are stable on medications, stopping the medications because of fear that it's going to hurt the fetus should not be the default. And I'm not saying that's not ever indicated. Certain medications should definitely be stopped, but it just should not be the default. And I think that applies to no area more than psychiatric conditions. I see patients so frequently who are 20 weeks or 25 weeks, and they have fluidly uncontrolled, whatever it is, depression, anxiety, bipolar disorder, because a well-meaning practitioner has told them, oh, you can't be on that during pregnancy, it'll hurt the baby. And there's some exceptions, but for the most part, that's not the right approach. There is an ACOG document on management of mental health conditions during pregnancy and the postpartum period. And it's not just focused on medications, but it has a lot of good information in it. And I've put it on this slide for review. Taking a family history, thinking about future pregnancy. I always ask about genetic conditions, and I typically start open-ended. And then if this patient says, well, no genetic conditions, I usually name a couple, and I usually just name cystic fibrosis, spinal muscular atrophy, and sickle cell disease. I also ask about any babies born with birth defects, and sometimes I ask it in different ways. Any babies babies or young children who died in childhood, anyone needs surgery in infancy or as a young child, just trying to elicit a history that might be suggestive of hereditary issues. I also always ask specifically about individuals with intellectual disability. And if the answer is yes, I really want to know, well, were they male? And that's getting at uncovering people who are at risk to have children with Fragile X syndrome. We can screen for the premutation state. And then when it comes to like a pure, medical history, something I always ask about is family history of venous thromboembolism, specifically in first-degree relatives, just trying to uncover, and sometimes you do, a patient who either needs thrombophilia testing and that, or otherwise is at higher risk for venous thromboembolism. As people probably know, pregnancy and the postpartum period are risk factors for that. And sometimes knowing this history will help us manage them a little bit differently. And I'll also just say that if in taking the family history, anything comes up that's confusing or seems like it's important or impactful, the preconception period is a great opportunity to refer to a genetic counselor. Of course, immunization status is also part of the medical history. And when you read about immunization specifically in regard to preconception care, they always talk about Tdap, and it's mainly the pertussis component, hepatitis B, MMR, and varicella. Varicella and MMR, because they are live vaccines, are considered contraindicated during pregnancy. And if it's indicated to immunize the patient, this should be done at least 1 month prior to conception. It is important to note, though, I think that there are registries for both varicella and MMR, and I think the registries are now closed. But they're registries of people who inadvertently got those vaccines, either in very close proximity to conception or during pregnancy. And the data is very reassuring. Essentially, no cases of congenital varicella or rubella from the vaccine. Still, though, we want to give it prior to pregnancy. This slide just has 2 references that I think are particularly helpful. And just for time reasons, I'm not going to click on the links and go to the websites. But the first one is from CDC, and it's a really nice tabular format of the routine vaccines and whether they're okay in pregnancy or not. That's the first part. If you scroll down, there's another table of the less common vaccines, which I would call like more travel vaccines, dengue, yellow fever, anthrax, things that we're not typically giving patients, as well as the status of whether or not they're okay in pregnancy. So this first website's more geared for providers. The second website is more geared toward patients. And this is from the SMFM, which is Society for Maternal Fetal Medicine website. For a lot of the website, you have to be a member, but for this link, you don't. Like I said, it's more geared toward patients, but it's a really well laid out, just user-friendly and visually appealing website with a lot of infographics and information about vaccines and pregnancy. Infectious disease screening, of course, as with anyone, if they're a high-risk demographic, tuberculosis screening, gonorrhea, chlamydia, HIV, hepatitis, and then syphilis. And the bolding and the emphasis is mine. I just wanted to take the next couple slides to specifically talk about syphilis. So this graph here shows the concomitant rise in syphilis among women of childbearing age, concomitant with the rise in congenital syphilis. And the data is the data. I would not argue with it, even if my experience didn't line up. But I can tell you just clinically, and I'm sure everyone here probably has seen the same thing, this absolutely tracks. This graph on the left side starts in 2012, and that's when I ended my fellowship. And we learned about syphilis. We're tested on it. It's on oral boards. It just rarely came up, frankly. And fast forward to now in the last couple of years, where it's a very common reason that we're getting patients referred to us. Syphilis, of course, crosses the placenta, so it can cause congenital syphilis. This graphic here is from a recent review paper that I found particularly helpful. It's from the New England Journal of Medicine, and this graphic just depicts all the organ systems that congenital syphilis can affect. Syphilis also affects the placenta. Not only does it cross it, it affects it. That can lead to stillbirth, low birth weight, and because of all of that, NICU admission. And we do screen universally for syphilis in pregnancy. Actually, now it's 3 times in the course of pregnancy and the delivery hospitalization. Early treatment is key, but just, there's a little bit of a delay in getting prenatal care. And then even if you get prenatal care early, it takes a few days to get labs back and then confirmation, calling the patient. So, even somebody who's getting pretty early prenatal care could easily be second trimester before syphilis is treated. And because we know that spirochetes cross the placenta as early as the mid-first trimester, again, knowing this prior to pregnancy and getting treated prior to pregnancy is beneficial. This next slide packs a lot of things into a couple of neat bullets, and clearly each of these can be their own talk, but screening for substance use, screening for intimate partner violence. We know that, unfortunately, intimate partner violence often escalates during pregnancy. And then I do feel bad only saying nutrition and weight optimization in one breath. Clearly, that's a very important topic, but optimizing weight prior to pregnancy is probably in the top few things that we can do to modifiable risk factors to impact pregnancy outcome. These next 2 slides are not things that I've really seen talked about in preconception counseling. They're just things that I think are important and that I think about. And one is medication allergies. And I suspect this is a big topic in medicine in general. I guess I don't know exactly. It's definitely a big topic recently in OBGYN. There have been a lot of papers that I've seen, both original research and review articles recently on this topic. So if the patient has a lot of allergies, particularly if they're antibiotics and particularly if it's penicillin, depending on their history, just thinking about multi-drug resistance and being a good steward of antibiotics, referral for allergy testing is something to consider. And the last thing I have here under medical history is just to think about whether or not a patient needs an antibody screen. And I know that people who are not obstetric providers don't really think about alloimmunization, but that is, if you don't know, where a mother has an antibody, one or more antibodies to antigens on red blood cells. If those antibodies are IgG, they can cross the placenta. And if she's carrying a fetus who has the antigen to which she has the antibody, that can lead to fetal anemia, stillbirth, and that is something that we can screen for in pregnancy and potentially impact. So in someone who is high risk, someone who's had frequent transfusions, it is important to think about an antibody screen. Some of the reasons why people would have frequent transfusions would be medical issues, and that's beyond the scope of this talk, but patients that come to my mind who would still be considered healthy but would be at risk is someone, for instance, who's had transfusion due to trauma. those patients can have antibodies, and knowing about that ahead of time is helpful. Moving now into genetic counseling and screening, and I've put up here references to 2 helpful ACOG documents. So ACOG and other organizations too say that women who present for pre-pregnancy counseling should be offered screening for the same genetic conditions as recommended for pregnant women. Well, what we're talking about here is screening for carrier status, mainly autosomal recessive disorders, in some cases X-linked disorders. And this is something that we offer in pregnancy if the patient hasn't already had it. But ideally, it's performed prior to pregnancy. It just allows you time to get the result and deal with that result. Educate the patient and family. If it's applicable, for instance, autosomal recessive conditions, screen the reproductive partner. And then if both partners are carriers, then they can be counseled on the risks and consider the range of reproductive options. I originally had more slides on this topic. It is a big topic that's rapidly evolving, and I had to take a lot of them out due to time constraints. I will just say that this slide is what is the minimum that is recommended that we offer patients. And it used to be ethnicity based. These cystic fibrosis, spinal muscular atrophy, and hemoglobinopathies are no longer ethnicity based. Those should be offered to all patients. Select patients should be offered screening for Fragile X syndrome. That would be patients with a suggestive family history. And as I mentioned a few minutes ago, that would mostly be patients with a family history of male individuals with intellectual disability. If the patient herself has premature ovarian failure, that alone is an indication for screening. Patients who have Ashkenazi Jewish descent should also be offered screening for Canavan disease, familial dysautonomia, and Tay-Sachs. And I don't have it on this slide, but another group of individuals at risk for Tay-Sachs disease is people with Cajun or French Canadian heritage. So that's the minimum we should offer. There is now, though, the option of what is referred to as expanded carrier screening. And what that is it uses next generation sequencing. And I'm not even going to pretend to understand all the technology behind it, but essentially the labs can screen for many, even up to hundreds of conditions simultaneously and at about the same cost as the standard panels that we used to offer, where it was only about four disorders. There are multiple companies that offer this, multiple different panels, and you have to choose what panel you want. I will say that our resident OB clinic, they offer a panel that tests for 14 mutations. Our genetic counselors through MFM, they're flexible and they'll do what the patient wants, but the standard that they offer is a panel with testing for 421 mutations. This sort of expanded carrier screening does require genetic counseling, and I'm not saying that has to be a technical genetic counselor, but you do have to understand how to counsel on results. You have to understand that there is still a residual risk. The patient needs to understand that. These companies that offer this testing, they have websites and references that you can look at to counsel on residual risk and what that risk is. And residual risk, if it's not clear, would be if they have a negative screen, what's the chance that they're still actually a carrier? And it depends on the disorder and in some cases on ethnicity. The other thing to think about, and this is probably obvious, but of course, the more things that we screen for, the higher the chance that the panel is going to come up positive. And with the traditional approach of just offering a few things and only ethnicity based, about 5 to 10% of them would come up positive with something. With these new expanded carrier screens, depending on what the panel is and how much it screens for, as many as 2/3 of patients will have a positive result. So that requires a lot more follow-up and resources. The last section of my talk, I think is just the next 2 slides, focuses on pregnancy timing. So for patients who have had a prior pregnancy, there's a concept of the intra-pregnancy interval. A short inter-pregnancy interval it's defined variably, but usually it's defined as somewhere between less than 12 to 18 months between delivery and conception. We know that short inter-pregnancy intervals are associated with a higher chance of complications like miscarriage, preterm labor, or preterm delivery, and low birth weight. And essentially, it's recommended to, the bottom line is it's recommended to wait at least 18 months between pregnancies, at least 6 months though. WHO actually recommends 24 months between pregnancies. And then, of course, I wanted to just mention contraception again, because obviously that's important in order to be able to optimally time pregnancies. This is the last slide before my summary slide. I just felt like this was a good place to address the issue of advanced maternal age, because clearly this factors into a lot of patients' decisions on delivery timing. The definition of advanced maternal age is if the patient is 35 years or older at delivery. We do acknowledge and recognize that 40 up is a higher risk group, and of course, advanced maternal age in itself is a continuum. And there are guidelines through ACOG and SMFM for management of pregnancies where the woman is advanced maternal age, and those guidelines recognize that 40 plus is a higher risk group, and some additional things are recommended for that group. This is just something that I feel strongly about, it's just my opinion. But I feel like if the patient is otherwise healthy, particularly if she's had uncomplicated pregnancies, I feel like it's important for us to be relatively reassuring about this, in that it is a true statement that most patients of quote unquote advanced maternal age have, if not an uncomplicated, then at least a relatively uncomplicated pregnancy and healthy term baby. That said, I do counsel patients on the risks, and I always tell them that there are two reasons why advanced maternal age is a thing, why it's a diagnosis. The first thing is that it is true that the chance of aneuploidy, and Down syndrome is not the only one that increases, it is just the most common. The chance of aneuploidy does increase with advancing maternal age. It is actually increasing throughout the whole span of life, though. It's higher at 30 than at 25, for instance. There are charts you can look at to quote someone the chance of having a child with Down syndrome based on age. This is just the chart that I use. There's slightly different numbers depending on what chart you look at. But this can kind of give patients a ballpark for their risk. I then tell patients that the second reason why advanced maternal age is a diagnosis is that it is true that to some extent as you age, the chance of complications like preeclampsia, gestational diabetes, even stillbirth goes up. And I think it's important for patients to know that. So we just went through a lot of information quickly. This was not comprehensive just because of time constraints, but hopefully I've given you some information to think about. In summary, we should all, and I'm including myself in that, use every medical encounter we have with a pregnancy-capable patient to at least think about preconception counseling. Remember that one key question, just asking, do you want to become pregnant in the next year? If the answer is no, contraception, or offer contraception. If the answer is yes, then proceed to preconception counseling. The second bullet here, I tell patients all the time that the most important thing we need for a healthy baby is a healthy mom. And I just want to stress that, in regard to this, routine primary care is preconception care, just optimizing mom's health. We also, of course, want to optimize future fetal health, which is largely done by optimizing maternal health. Also, remember folic acid and avoid certain medications. We need to offer genetic screening or refer for that. And then finally, just don't forget about contraception. Thank you very much. And I am happy to be contacted anytime if anyone has questions. And here's my email.
Thank you so much, Dr. Lynn. That was fantastic. Dr. Zemo is pulling up her slides. You can see in the Q&A, there's some questions. We can answer them at the end, or if you want to type in the answers about respiratory virus vaccines and how to test for alloimmunity. And next is Dr. Zemo.
Hey there, thanks everyone for being here. And thank you, Dr. Unal, for running through that. I took pictures of a few of your slides. Those are great resources, so thanks for that. I'll talk a little bit about preconception management of chronic conditions. And likewise, this is a huge category, but we'll cover what I hope are some of the most pertinent and kind of high yield things today. Real quick, I have no financial disclosures. And so to start with, we're going to talk about the implications of chronic medical conditions in pregnancy, and then the specific importance of preconception care in that population, and then talk about some best practices for management. Because of the limited time, I think hypertension and diabetes are some of the ones of greatest interest, but I have a couple quick hits on obesity and thyroid as well. So to start with the implications of this. First of all, with increasing frequency, pregnant women have medical conditions that must also be managed when considering their reproductive health, including pregnancy. So at this point, more than half of US women who become pregnant have at least one pre-pregnancy diagnosis. That includes things like obesity, hyperlipidemia, hypertension, and diabetes, but also things like obstructive sleep apnea, mood disorder, cardiac conditions, etc. And this is increasing over time in the US as well. So increasingly is becoming something that we need to think about. And then importantly, more and more work shows the clear consequences of this on pregnancy outcomes. So this study looked at several cardiovascular risk factors, including hypertension and diabetes, and their association with adverse outcomes. And across outcomes, there's sort of a dose-responsive effect seen that those with more cardiovascular risk factors are more likely to have adverse pregnancy outcomes. And so it's something really important to think about when interacting with pregnancy-capable patients. To give you an idea of the risks involved with more specific conditions or individual conditions and risk factors, chronic hypertension and diabetes are both associated with ICU admission for the birthing parent. Chronic hypertension has a much higher mortality as well. Risks of preterm birth, low birth weight infants, and fetal death are also much higher in these groups. And then obesity, aside from its contribution to things like hypertension and diabetes, also has its own independent risks associated with developing hypertensive disorders of pregnancy in gestation, as well as gestational diabetes. And where primary care doctors come in is that these outcomes for patients with chronic medical conditions improve with pre-pregnancy control of disease. The risk is not static. In multiple conditions, this has been shown that both pre-pregnancy visits with just routine care, as well as discussions of contraception, are associated with improved pregnancy outcomes, and especially in diabetes, improved control of diabetes before pregnancy is associated with better control in the first trimester of blood sugars, a reduction in congenital malformations, like Dr. Yunal mentioned, as well as reduction in perinatal mortality, small for gestational age infants, and a lower risk of babies being admitted to the neonatal ICU. So there's really a potential for providers to make an impact on the outcomes for patients here. And so, like Dr. Yunal, I'd like to kind of emphasize that any medical visit is an opportunity to plan for a healthy pregnancy, and especially in populations of women with chronic medical conditions. Studies have shown that women with chronic conditions, while you might hope that we're doing a better job of helping them time pregnancies when their disease status is controlled, have similar or higher rates of unplanned pregnancy. And then when the pregnancy is planned, it's also associated with improved outcomes. So that is to say that most patients are not walking into the office and telling us that, I have 6 months notice, I'm hoping to be pregnant in a year's time, what can we do? Many of them are coming in with unplanned pregnancies, or it's not being discussed. And so any and every visit is an opportunity to address their increased risk in pregnancy and to optimize disease control to help improve their outcomes. So kind of moving on to what we can do in management. The way that I conceptualize this myself is that there's kind of a bi-directional relationship, and both things need to be considered when thinking about any disease in pregnancy. The first is the effect of pregnancy on disease. How is their disease control going to change once the patient becomes pregnant? And this varies for different conditions. And then how is the disease going to affect pregnancy? So what outcomes are they at risk for? What could happen to the fetus? How is the pregnancy itself going to progress? And so since I'm kind of limited in time, and we're going to focus on diabetes and hypertension the most, I just wanted to first provide a general framework that can kind of be applied to any condition that you're discussing in the preconception period. So starting with, like Dr. Unal said, asking that one key question, talking about contraception if patients don't want to be pregnant, and trying to time a pregnancy such that, you've been able to address disease control, it's a planned pregnancy, etc. Second, to address disease status or assess disease status. Is it controlled? Is it not controlled? Getting baseline labs and assessing like function and end organ damage related to the condition. Then moving on to optimizing disease control with first a focus on lifestyle factors as appropriate, and then thinking about whether there are pregnancy-specific target metrics, which we'll get into a little bit, that you need to keep in mind that are different from patients who are not planning pregnancy or pregnant, and then making sure that patients are on pregnancy-safe medications. Patients should, be informed about the risks associated with whatever condition they have. And so this is a good time to have that kind of like risks benefit type of discussion, more just so that they are aware of the implications than, necessarily advice against pregnancy. And then engaging the multidisciplinary team as well. So if there's a subspecialty physician that they need to be seeing, or if they, like many patients with chronic conditions, would benefit from seeing MFM before pregnancy, this would be the time to go ahead and do that and have them see those providers so that they have established links of care. And then also applicable to kind of all conditions, I just wanted to share my two favorite resources for assessing medication safety in pregnancy and lactation. LactMed is kind of a more like comprehensive, thorough, but a little clunkier resource that's, you want to read it on your computer screen, go through all the data, etc. Infant Risk Center is a great app that gives you by trimester and the lactation period, whether a medication has been studied or not, and whether it's relatively safe or not. So just wanted to share those couple of things. So moving on to preconception management of chronic hypertension. First, to start with, what is our goal when treating chronic hypertension, either pre-pregnancy or in pregnancy? Historically, there was this concern about treating women with mild hypertension who are pregnant or planning to become pregnant. And that's because in the first trimester, the blood pressure drops. And so the worry was that treatment would drop blood pressure too low and lead to hypoperfusion of the placenta and the fetus and lead to growth restriction and poor outcomes, etc. And so for a long time, there was this thought that we shouldn't treat blood pressure in pregnancy unless it's over 160 systolic or 110 diastolic. But in the last couple of years, and published in 2022, which I guess is 3 years ago now, but the chronic hypertension and pregnancy trial looked at in pregnant patients, what was the impact of treating to a goal blood pressure of less than 140/90, which is their intervention, versus the, traditional way of treating this, which is a blood pressure goal of less than 160/110. And what they saw in this group was a composite outcome of adverse pregnancy outcomes that was decreased, and that includes preeclampsia, medically indicated preterm birth, placental abruption, and fetal death. And so ultimately, the Society of MFM has adopted, as well as their new blood pressure goal in pregnancy, less than 140/90. And so the same, I would say, goes for women who are planning to become pregnant, that you don't need to worry that they're going to become pregnant and then suddenly kind of tank their blood pressure. We should continue to target that goal. When you are treating for hypertension and planning for pregnancy, labetalol and nifedipine are really the preferred antihypertensive agents. All of the guidelines list methyl-dopa as well, but I would say is much less broadly used. It's been shown to be safe, which I think is why it's still in the guidelines, but a side effect profile, and so I haven't seen it used very much. Hydrochlorothiazide is probably for more complicated patients, should probably be managing these collaboratively with MFM, like really difficult to control blood pressures. And then ACEs and ARBs are contraindicated because of their teratogenicity. In terms of a lab assessment that you would do on these patients, mostly looking for end organ damage as a consequence of hypertension. So initially, electrolytes, looking at signs of secondary hypertension as well here. Renal function, looking at hypertensive nephropathy, which is also kind of a form of risk stratification for these patients, since if they do have renal dysfunction, they're at much higher risk than patients with hypertension and no renal dysfunction. A CBC, looking especially at platelets to kind of give a baseline for later evaluation in pregnancy, as well as the spot urine albumin to creatinine ratio, looking both at renal function, but also, later in pregnancy, if they're being evaluated for preeclampsia, having a value from before pregnancy to compare this to. And then in select patients, specifically those that are more likely to have some cardiac maladaptations as a result of their hypertension, a cardiovascular risk assessment. So people who have really poorly controlled blood pressure, who have had hypertension for a really long time, or who are older than 30 and so maybe have had high blood pressures for longer, starting with an EKG to see if that's normal or abnormal, and then if there are any abnormalities, moving on to a TTE. And then thinking about secondary causes of hypertension, really getting at wanting to optimize control before the pregnancy begins. Young age obviously makes up a lot of the reproductive age population, but should still be thinking about it. But any red flags like absent family history, no lifestyle risk factors that kind of make you less surprised that someone's hypertensive, especially obstructive sleep apnea is something to think about because that can worsen in pregnancy as well. And then other kind of associated systemic symptoms. All right, so to move on to preconception management of pre-gestational diabetes mellitus, so not gestational that had developed in a prior pregnancy, but people kind of with baseline diabetes. Like Dr. Unal talked about, the kind of mentality about this is that the impacts of hyperglycemia are happening very, very early in the pregnancy, early in conception, during the process of organogenesis. And so the idea is that mom is hyperglycemic, the blood sugar passes through the placenta, the fetus is hyperglycemic, and then because of that, the fetus also has hyperinsulinemia, and like all of this contributes to a disordered fetal growth. Because this is all, I think about it the same way as with folate, that in diabetic patients, we're trying to optimize blood sugar before the pregnancy even begins. So because of that, the goal is a lot more strict than in like our general patient population. And we're looking at an A1C between 6 and 6.5 to make sure that there's really euglycemic control. In trying to reach that goal, nutritional counseling is really critical for these patients. Either with a dietitian, nutritionist, or a diabetes educator to talk about things like what does glycemic control look like, checking your blood sugars, using your insulin if they are already on it, talking about a diet that would target 5 to 10% weight loss if they do have an obese BMI. Carbohydrate counting is not something that we talk about like kind of routinely with all diabetic patients as much, but specifically in pregnancy, this is kind of a cornerstone of management. And so getting them used to that process early, can be beneficial for their control later. And then because we're targeting really stringent blood glucose measurements, educating them and their families about the signs and symptoms of hypoglycemia and how you would intervene in that kind of situation. And then if you can't reach, optimal glycemic control with just lifestyle interventions, nutrition, exercise, weight loss, it is still true that in pregnancy, insulin is the preferred agent for treatment of either pre-gestational or gestational diabetes. Unfortunately, oral agents, a lot of the safety of these agents is either unknown or has like some early animal study or observational signal that it's an unfavorable risk. The exception is metformin. in patients with gestational diabetes or diabetes in pregnancy that kind of decline insulin or can't use insulin for some reason, it's a reasonable alternative and patients do use it. But it's important to know that the glycemic control is kind of less optimal than with insulin, though it does seem to be very safe. On that note, I just want to touch on GLP-1 since we're seeing a lot more of these in practice and in younger patients as well. The bottom line is that we just don't have a lot of good data about the fetal risks or the effectiveness of these agents on controlling blood sugar in pregnancy. There's some animal studies that show a risk of harm. When looking at FDA surveillance data, there's like maybe some signal that there are small risks. Reassuringly, there are observational studies of patients who have been on GLP-1s and kind of had unintended pregnancies, and there don't seem to be like high risks of congenital malformations, et cetera. But overall, there's just really minimal information. So I would probably reassure my patients, if they happen to become pregnant while on one, that this isn't like a catastrophic situation. They can like be reassured that there doesn't seem to be any huge side effect on the pregnancy, but the current recommendation is to discontinue these agents 2 months before becoming pregnant. Similar to in hypertension, looking for sequelae of diabetes in these patients, assessing their baseline disease control with an A1C, of course, looking for diabetic nephropathy as well. Again, important for kind of risk stratification as well. Hepatic function, kind of looking at greater metabolic syndrome, et cetera. And again, important for baseline, especially when assessing preeclampsia and things like HELP later in pregnancy. A TSH, especially in type 1 diabetes, this can be associated. And so assessing before pregnancy where their TSH is, since this can be affected in pregnancy as well. Again, assessing for proteinuria before pregnancy as your baseline. A lower extremity exam as well, specifically interested in looking at pulses in the lower extremities to get a sense of whether there are signs of vascular disease as sequelae, since this is a much higher risk in pregnancy if they do have existing vascular disease. And then a retinal exam as well, which I want to talk about just a little bit more. So it's a recommendation that all patients with diabetes be screened for diabetic retinopathy prior to pregnancy. And so the idea behind this is that the same thing that's happening throughout the body that leads to a decrease in systemic vascular resistance and lower blood pressure systemically is happening to the blood vessels in the eye as well. And so there's a high risk of progression of diabetic retinopathy in patients who have it. And so to both get a baseline understanding of whether they have retinopathy so that they can be screened during pregnancy, and so that if they have proliferative retinopathy specifically, they can be treated with like laser therapy before the pregnancy occurs, basically just reducing their risk of vision-threatening progression. Like with hypertension, I'm doing a cardiovascular risk assessment in select diabetic patients. If they have other cardiac risk factors, certainly this would be a population that's higher risk and would warrant a cardiovascular risk assessment. If they have evidence of vascular disease, so kind of getting back to that pulse exam, are there any other signs that they already do have existing cardiovascular disease? And then if they're greater than 35 years old, because they're higher risk already. So that's kind of what I wanted to talk about with hypertension and diabetes. I think we do have a couple of minutes to just give some quick hits on obesity and hypothyroidism, just because those are so common. I would say in in obesity, one thing that I think is important to share with patients is as we're doing our lifestyle interventions for diet and exercise, also discussing the risk of subfertility in these patients, because the benefit to them of the lifestyle interventions is both that they may be more likely to become pregnant and that they're more likely to have a healthy pregnancy. Share the risk of adverse pregnancy outcomes if they were to become pregnant. And like I shared before, a low threshold to screen for obstructive sleep apnea, since this is something that can be kind of optimized prior to pregnancy and does worsen in pregnancy. On the kind of less recommended side of things, not really known how to recommend bariatric surgery to patients planning pregnancy. Certainly, it can be very effective for weight loss, but especially in the first 2 years after surgery, there are higher risks, both from a surgical perspective and due to nutritional changes after the surgery, increasing risks of small for gestational age infants. And then with GLP-1s, which we talked about a little bit, there is a concern that because you're gaining weight in pregnancy anyway, is there even worse rebound weight gain when discontinuing GLP-1s in pregnancy? So really unclear at this point whether you kind of want to optimize weight before pregnancy using the GLP-1s. Hopefully we get more information about that soon because it could be really helpful for people. And then in terms of hypothyroidism, just quickly wanted to mention, because it's kind of a quick intervention that we can make in the primary care space. Lower TSH, especially with assisted reproductive technologies, has been associated with improved fertility. And so there's kind of a lower threshold in patients trying to get pregnant to treat a higher TSH. Those who are already pregnant and have a higher TSH get evaluated for the presence of antibodies. But in the primary care setting specifically, I typically give patients kind of this anticipatory guidance if we're treating hypothyroidism, that if they were to become pregnant, please give us a call right away and we can go ahead and increase the dose of your levothyroxine, because the physiologic level is just higher. There's a higher need in pregnancy. And so your goal would end up being a TSH of less than 2.5. So that's what I had. Thank you so much for listening. Happy to answer questions as well, and happy to have anyone reach out to me anytime. I have my references here. They were throughout. But thanks very much.
That was great. I did the same thing, took some screenshots. That the Infant Risk Center app looks super helpful. Let me close. So Dr. Ernal is answering some of her questions in the Q&A. And Dr. Zemo, you might get some there too. I am going to share, if you want to stop sharing, Jess, and I will share, unless I don't know, maybe I could do it at the same time. Okay, so what I'd like to do is close. We've got about 8 minutes. I can do it. I'm going to talk about IDPH resources that I could not have set this up better from the things that you two talked about, to say, like, look at your tax dollars at work in this space. So hugely important question. That one question, do you plan, would you like to have children in the next year? I'm a big fan of QR codes, so I have them in the next few slides. One of the things is low or no cost family planning services are available through Title X clinics, which is federal and state funding. Quite in the crosshairs with the current administration, but so far they're there. And there's also a recent expansion of our state Medicaid program for family planning services. So if you have a patient that struggles to get access to contraceptive care, there are options for her. We also have, for if you have a person who's pregnant or planning to be pregnant and needs the routine screening for breast and cervical cancer, the IBCCP program also has statewide brick and mortar clinics that can offer low or no cost screening. Obviously, those can be done in pregnancy too, as needed. Many of the resources that are state-funded resources have been developed from the maternal mortality Review Committee, which Dr. Unaluma is a member. This meets monthly to review every death in pregnancy or during pregnancy or in the year following to see if they were associated with the pregnancy. And this most recent report gave these numbers of the causes of death for pregnancy. And because of this, this document, the report makes recommendations, including recommendations for services for things that could be helpful. So one of the biggest ones, because you can see, let me go back, the substance use disorder, mental health conditions resulting in suicide, there's lots of overlap there. So one of the things that was developed through IDPH and HHS is the medication-assisted recovery resources for opioid use disorder. The medication-assisted recovery MAR Now program is a 24/7 line for pregnant, non-pregnant folks to call to get connected to care managers to help with Suboxone, counseling, rides, etc. So it's really a one call for providers to connect folks to this care. And it's huge because so many of these things, pregnancy is excluded, but in this, it's okay if they are currently pregnant. Hopefully a lot of you know this. You can get boxes of Narcan for your clinic. It's a quick survey. Here's my clinic, here's a zip, etc. And you'll get boxes. And we really try to keep those. I see patients at Stroger, and we try to really make sure that we have a very low threshold for sharing the Narcan with our patients who may need it for themselves or their loved ones. And again, just to love this following, one of the things that has been started at the state level is a provider, perinatal syphilis provider warm line. It's for folks who are currently pregnant, but it is a resource that's been there for about 1.5 years. It's clinical guidance. Think of it like a curbside with maternal fetal medicine, adult and peds ID, to talk about a currently pregnant patient approach to her care, what stage the patient is, and the best treatment. And the warm line also will do public health record searches since syphilis is a reportable disease. They can look up and see where in the state or even other states she has been treated and what her labs were other places. A warm line took me a while. A warm line is different than a hotline, that it's not answered immediately. It's answered within 1 business day. So I am going to stop here. We got 3 minutes. This is to first thank you all for all the work that you do in the trenches. It is a surprising challenge to be able to communicate easily with providers who care for women. Pediatrics has the Illinois chapter of AAP has a great listserv. ACOG is much more cautious with sharing the emails of our folks, so we're sort of doing a bit of a workaround. And I'm going to close this, so that's to be added to our listserv. Again, you'll all get these slides, so all these QR codes will be there. I'm going to stop this and see if there's any other questions. I think that they were all answered. You know what? I realized that I did not, David's reminding me, I did not do a few other things. Coming up for Fast Facts, very hot, sadly, hot topic in May, measles, tick-borne diseases in June, and a little back to school info for July. There is this QR code links, there is a way to be connected to the Medical Services Division. There's myself, a pediatrician, internal medicine, peds ID. So there's a bunch of clinicians. If there's anything we can do, please reach out to us. The Siren, many of you hopefully know this, but the Siren is the state notification platform for issues that are happening. Super helpful, especially for some of these respiratory things, outbreaks, etc. So if you're interested in signing up, you can specify exactly what you'd like to hear about. And then CME credits are available, that you have to answer a couple of questions. And again, this will be in the slides that you get. All right, look at this. We are a minute. Beautiful. Nothing worse than going over. Let's see. So Kai Tao added a helpful information for contraception that Title X is one way to help folks pay for contraception. The family planning program within the state is another way. There's something called the SPA. There's some Medicaid expansion specifically for family planning. So there are ways, other ways to get contraception. All right, I think we have answered most of them. I don't see anything else. All right, right on the hour. Thank you all for joining. Thanks, Drs. Unal and Zemo, for your help. Really appreciate it. And this will be recorded and live in eternity for anyone who wants to know this information. So thank you all. Take care. Bye-bye.